right, section 411 is establishing a public option for health insurance. And I guess we should just clarify what exactly is a public option. This would be a government-run health program, and every American would have the ability to choose from that program or private insurance. Private insurance wouldn't be prohibited. This would just be an option for a government-run health program. And a public option has a number of benefits. Some of them include the fact that because it's government run, it's nonprofit. Private health insurance companies make tremendous amounts of money, and government programs wouldn't have that same drive. Also, because it's a nonprofit, there'd be no taxes to pay, which would also help keep costs down. In general, administrative costs would be lower than with private insurance. According to the 2021 annual report of the boards of trustees of the Federal Hospital Insurance and Federal Supplementary Medical Insurance Trust Funds, which is a long way of saying the Medicare program, they reported that their administrative expenses were $4.5 billion, or 1.1% of their total costs. Put it another way, 98.9% of expenses went to benefit payments. Now, if you compare that to private insurance, they pay 80, 85%, maybe as high as 90% out in benefits, but they have a lot more administrative expenses, as well as profits and things that mean that less of their premiums actually goes to provide healthcare. A government program can do this with lower administrative costs. Government program would also have better bargaining power to compete with private insurers, because it would be one national negotiation. I don't know if you noticed that sometimes you get conflicting arguments from people opposed to this kind of thing. One of them is that, well, government is incompetent, and so that privatizing things is the way to have the most efficiencies. And the other argument is that, well, it's unfair if government competes, because they would be able to offer services at a lower price because of their size. While the government may be incompetent on some things, if we can provide cost savings to the American people, as well as provide these other benefits through a public option, I think we absolutely should. Other benefits are this would be portable. This is billed as part of the American Union's job program, which we'll talk about in a later hearing, that as every American gets an American Union job with and universal basic income, they also get the opportunity to buy health insurance, which they can take with them no matter where they are around the country. Give Americans the freedom to move around the country and have insurance and income move with them. And by being a national plan, it would further offer efficiencies. What do people think about a public option? And the vast majority of people support it. The March 2021 Politico survey found that 68% of voters supported a public option, a higher percentage than supported a Medicare for all. And so this is incredibly popular with the voters. 80% of Democrats and 56% of Republicans supported a public option, which is perhaps one of the reasons that Joe Biden campaigned on it in 2020 and defeated Donald Trump. But there hasn't been really any progress on providing the American people with a public option, despite the fact that our president campaigned on it and that more than 2/3 of voters would like to see one. And so we can address that in 2022 with the Blueprint for a Better America. Now, this section 411 is based on previous legislation that has been introduced in Congress, and it would add a new section to the Affordable Care Act. And just to kind of go through some of the details briefly, the Secretary of Health and Human Services would be responsible for putting together the public option and the specifics of the plan. Beginning in 2024, they would be offered through the healthcare exchanges that the Affordable Care Act set up. I also want to emphasize that the public option would be voluntary. No one would be obligated to buy their insurance through it. And the legislation says so specifically on page 99 of the Blueprint, that participation in the public option is voluntary. The secretary would put together a number of plans, a standard bronze, silver, and gold. If you've shopped for health insurance on the exchange, you're familiar with those. And then there would be an option for a platinum plan, depending on how costs and things work out. Premiums could be geographically adjusted, and premiums would be set in an amount to cover the cost of administration and health benefits. So figure out what will it cost, and then set the premiums at that, plus a 90-day contingency margin for unexpected expenses. And so these startup costs would be the 90-day margin plus $2 billion, and that would be repaid over 10 years. So this would be a cost neutral to the rest of the federal government spending. There would be no bailouts, another thing that specifically is specified in this legislation. This would be a completely separate program, self-funded, to provide health insurance to anyone who wants it. The public option would also require negotiation for prescription drugs. We're going to talk about that a little bit in the next section. It would set up a provider network. As the default, any hospital or any doctor who participates in Medicare right now would be included, but they would have an option to opt out after the program gets started. They start working out details in 2023. Doctors and hospitals would have at least a 4-month window to opt out, and then an annual enrollment period where they could change their status. The reimbursement rates, payment rates under the public option would be set at the Medicare reimbursement levels, plus there'd be a 5% incentive bonus for the first 3 years. Physicians would be divided into 2 classes: the preferred, who agree to accept this payment rate, and then participating non-preferred physicians, who agree to cap their charges at 15% over their in-network cost-sharing price. And then any other physicians or doctors who didn't want to participate would be non-participating. Subsection D of this section, it offers options for the secretary to experiment with different reforms and ways of bringing down healthcare costs. Some of the policies that they could try would include patient-centered medical home care. It would accountable care organizations, value-based purchasing, bundling of services, differential payment rates, performance or utilization-based payments, a fixed payment per person, or direct contracting with providers. And the secretary could try these out in different locations and sort of see what works. And then if they, pick out the best plans and expand them, roll them out nationwide. Anything that they tried under these provisions would have to, quote, promote care that is integrated, patient-centered, high quality, and efficient. In addition, it would also have to be aimed at least one of these 5 targets: improving health outcomes, reducing health disparities, including racial, ethnic, and other disparities, providing efficient and affordable care, addressing geographic variation in the provision of health services, or preventing and managing chronic illnesses. So any experimentation would be targeted at least one of those 5 things. Other subsections in this part, they include protections for individual health information. The same protections that apply to other health plans would apply to this too, including HIPAA. And so overall, this would give the American people another choice. There's a lot of reasons for people to be dissatisfied with healthcare in this country. As a nation, we pay more per capita than any other country on the planet, and leave tens of millions of people uninsured. So there's better ways to do things. And the logical first step to be a public option, since our president has already promised us one of these. And and we saw at the start of the pandemic, some more than 5 million Americans who lost their health insurance coverage when their jobs went away. We need a better model for healthcare in in the 21st century. And by decoupling employment and insurance, seems like a logical place to start. So with that, Mr. Chair, I think that concludes my testimony for section 411, and I'd be happy to answer any questions.
Thank you. Yes, I have a couple questions. I'll start with a very specific one. With target number 4, address geographic variation in the provision of health services. Is it possible that that could be negatively taken advantage of in a loophole sort of way to increase prices in certain areas rather than to decrease prices in sort of this kind of backwards interpretation of addressing geographic variation?
Oh, that target would be if they were trying one of the specific options for reforms and experimentation, such as the differential payment rates or fixed payment per person. And so I guess I don't think so. I don't think you could. I think these experiments would be sort of limited in their geographic range. And so I don't think you could, for example, raise the rates of someone in New York to subsidize the doctors in Georgia or something like that. Is that what you're asking? Is if that would be a loophole where one geographic region would pay more, so another geographic region would pay less?
Potentially, or I mean, there are a couple of different ways that could go because, depending on what you want. So addressing geographic variation, I think you could have the philosophy that that maybe prices should be different in different geographic locations, or you could take the philosophy that it should be the same everywhere. I think I'd probably lean toward the former, but I think you could argue in either direction, and I think it would be good to clarify that potentially
Sure.
in which way we want it to level out.
The premiums can be geographically adjusted in subsection B. It says the secretary shall establish geographically adjusted premium rates for the public health insurance option. So it would not be one uniform price nationwide. Presumably it'd be more expensive in high cost of living areas and less expensive in lower cost of living areas.
I do have a broader question. So you had stated that Medicare puts about 1.1% of their total cost toward administrative expenses, whereas private insurance is usually at least 10%. So the first question would be, do you foresee the government outcompeting private insurance almost completely? And if so, what would be the point of delaying that? Why not just cut to the chase and do things in a more efficient way?
Because politics is the art of the possible. And I don't believe it is possible for us to cut right to a single payer healthcare system at this moment. But the public option, is, so the arguments against sort of a single payer system have always been, it's socialism, it's taking away your choices and things like that. Healthcare is different than a lot of other services because it's not really optional. Like everybody needs healthcare. And so it's not really subject to the same sort of market forces that other industries are. The public option, we address that by ensuring that people have a choice. And if people want to buy private insurance, can continue to do so. But it may come to a point where a government plan is efficient enough that private insurers are less able to compete. We don't know. We'll find out. But this seems like a logical first step.